Yeah, Dr. Hema, I hope you are.
Are you able to see that, Vishnu?
Yeah, fine. Please go ahead. Fine, Hema, you can go ahead. Yeah.
So I'm Dr. Hema Choudur from McMaster University, Canada, and it is always an honor and a privilege to be back at KREST, where I started my journey with Dr. Kakarlu. So as always, I would like to share my experience with you all that I've achieved over these years. So we look at calf pain. It is a problem for the next 45 minutes. We'll use a problem-based learning approach, which is different from the traditional approach. I have no disclosures except for acknowledgements for educational images, content, including anatomy images from internet-based articles and journals. So what is problem-based learning and how is it different from what we have learned? So if you know, through medical school and post-graduation, all of us have gone through an approach which is the bottom-up approach. So we start at the bottom of the pyramid and go to the top. This is the traditional type of analysis. We can take an example of learning a language, let's say French. So how do we pick it up? We learn the phonetics, letters, vowels, words, sentences, then grammar, finally before we start speaking. So if you look at it, we're putting one block on the top of the other to get to our goal, which is learning the language. So we start distant from the language and we approach the problem slowly, component to component. But in the process, sometimes we're so much overwhelmed with the information or the data that we give up the target of reaching the goal. So that is the traditional type of learning. In the top-down approach, where you start at the top of the bottom of the pyramid, where it's a broad spec like this, and go downwards to reach your goal, we use a problem-based analysis where, for example, you say you're thrown into a room where everybody is speaking French. You do not know the vowels, sounds, you do not know the words, sentences, but everybody is conversing. It's like a child who learns the language. So by repeatedly seeing the context in which a particular sentence is used, your brain starts to recognize the pattern and you end up communicating in French. And this is exactly what children do. And this is what we apply to the approach that we use in medicine here at McMaster. So when we go through the medical school here, we use the problem-based learning, which is an innovative tool designed here. So what we do is the entire system of medicine. It was not like what we were taught, where we had the first year of anatomy, physiology, biochemistry, and then the second year you go on to pathology, microbiology, before you actually exposed to the clinical scenario. Here we have, from the first year onwards, modules of CVS, CNS, musculoskeletal, GI, etc. So then we just have problems in each of these modules, each one for about 4 months. So let's say we're taking GI. So the problems that you have in GI can be vomiting, nausea, diarrhea. It could be different types of GI problems. And then we learn how to approach that problem and treat it. So in order to do that, you'll have to learn the GI anatomy, the physiology, the pathology, and then you'll have to come up with a differential diagnosis and a diagnosis. And then what happens is once you're done with the module, you move to the next. So you know that there are only certain bridges that link one system with the other. So those are easy to remember. So when I'm doing GI, where am I connecting to the CVS or the CNS is only thin bridges. So that is the advantage of this type of the system. So we look at how we can treat calf pain using this problem-based learning, just to make it interesting for all of us. So let's say we have calf pain and we want to go about it. And as you all know, we just jump to the internet and type in calf pain and you get a whole series of different charts that give you this appearance as I've shown you here. You're inundated with information. So you go down to what we do: trauma, infection, inflammation, vascular, and tumors, just to narrow down the way you'd like to look at it. So when you look at trauma, in the traditional bottom-up approach, then you classify trauma into age, duration, location, unilateral or bilateral, symptoms, modalities used to make the diagnosis, pattern recognition in each of those modalities, differential diagnosis and diagnosis. After that, you'll read up infection, do the same thing, inflammation, and so on. So it is a lot of effort, as you can see. Now, if you use the PBL learning, let's see how we can do it differently. So PBL, I would go through about 10 cases, and then you try to identify how we use a pattern recognition. So here is our first case, a 28-year-old female with acute pain in the calf while playing tennis, unable to weight bear. So this is the simplest of the scenarios. Let's start here. On examination, she has bruising and swelling of the calf. She's unable to stand on tippy toes, and her x-rays taken were normal. So calf pain, you're looking at young athletes, and we all know that we use stress fractures as the first, or fractures in this case, rule out by x-rays. Then we go through the soft tissues, which would be Achilles or muscle pathology, popliteal artery, deep venous thrombosis, nerve entrapment as the neurovascular bundle, and of course, exercise-related vascular insufficiency, chronic exertional compartment syndrome, and complex regional pain syndrome. And we have to pick from all of these. So the easiest way now is to look at it after knowing the anatomy with the ultrasound probe. It's a direct approach, simple. All that you have to do is put the probe on the body. So let's first look at the anatomy. The anatomy of the region comprises of the medial and lateral gastrocnemius. If you dissect them separately, you see the soleus underneath, and there is an aponeurosis or connective tissue in between these two layers, in which runs the plantaris tendon, which connects from the lateral femoral condyle to the medial aspect of the calcaneus, and it runs along the medial aspect of the Achilles tendon. So that is the brief anatomy of that region. Then you put your ultrasound probe in the long axis plane and the short axis. In the long axis plane, you see the gastrocnemius, the soleus, the myotendon, and in the short axis plane, both the medial and lateral gastrocnemius, the soleus, and the aponeurosis in between. Now let's look at our patient and what is happening. So you can see that between the gastrocnemius and the soleus, there is a collection or hemorrhage. And notice how the muscle fibers have lost their fibrillary appearance from edema, and the tearing of the deeper aspect of the gastrocnemius muscle fibers. Also notice that there is a discontinuity of the myotendon. So we're looking at a myotendon rupture. We're looking at a tear of the medial gastrocnemius and associated hemorrhage in the aponeurosis between the two layers. You can do the same with MRI, but you can see how less the clarity and resolution is with MRI compared to ultrasound. Of course, in Canada, we have long wait times and huge amount of resources. So here is the hematoma between the medial gastro and the soleus, and the tear extends to the myotendon. Now let's look at some variants here. Here there's a big hematoma, so the sound is you're not able to penetrate. You increase the depth, and you can see that there is an aponeurotic hemorrhage without involvement of the gastrocnemius or the soleus. And in the second case, you can see that rupture. Now let's look at plantaris tendon ruptures. We said the plantaris runs in the aponeurosis. So if you see a complete hematoma, a long axis view that extends right up to the calcaneus, you're looking at a rupture of the plantaris tendon, because if you see the plantaris tendon, it is nicely seen beyond the myotendinous junction, and you can trace this in the short axis plane up to the calcaneus. If you're not able to trace that and you have a hemorrhage in that place, you know you're looking at a plantaris tendon rupture. So that gives us the differential diagnosis of what we call the tennis leg. It's fairly common in tennis players. It's an avulsion type of an injury, and you can have injuries of the medial gastrocnemius, soleus, and or the plantaris. And the plantaris is a vestigial muscle. Its rupture does not cause any loss of function, and it's self-healing. So you don't have to boot cast the patient for long periods of time, as you would have to do with gastrocnemius and soleus injuries. So the treatment is different, and that's why one has to actually identify what structures are involved. So let's move on more distally. The ER physician finds that there is a defect in the region of the Achilles tendon, and then he does the Thompson squeeze test. So when you squeeze the calf, but if there is no movement of the foot in the plantar direction, you know that there's discontinuity of the tendon and the diagnosis is made in the ER. They don't need imaging to tell them that there is a rupture. Then why is the patient being sent for MRI or ultrasound? Let's start with the MRI first. If you see in the MRI, it tells you where the retracted tone end is. That is the information that they need. And then what is the separation between the two ends? In this case, there is an osseous fragment at the base. So let's look at ultrasound and see how it is superior. Now, if you see this is the long axis of the Achilles tendon, which has ruptured, you can see that it has, the rupture is 7 centimeters proximal to its calcaneal attachment. And this is before the plantar flexion is done. You can measure the gap between the two ends and then do a plantar flexion and on dynamic assessment, see how close these two ends are coming together. If these two ends are within 1 to 3 centimeters, he knows, the orthopedic surgeon knows that simply putting a boot cast with the foot in slight plantar flexion will bring the two ends nearer together and the tendon will scar down. In most of these cases, we do not do surgery unless the patient is a competitive athlete or if the distance between the retracted tone ends is wider than 3 centimeters. So this is where ultrasound has the advantage over MRI, where a dynamic assessment is possible. Now let's look at the importance of plain radiographs. If you look at this particular case that I've shown in MRI, I said there was a density here. If you just go with the MRI, you do not know whether this is an avulsion fragment, in which case, why is the tendon separated from the avulsion fragment? But if you look at the plain radiographs, you can see that it is nicely corticated. This indicates that this avulsion was an old enthesiophyte or an old avulsion fragment, which is corticated. And this is a new rupture on an old corticated fragment. So it's an acute injury on an old one. So for this kind of problem solving, always look at plain radiographs first. Now let's move on to tendinosis. As we all know that this is the Achilles tendon, which has parallel collagen healthy type 1 fibers. It is the parallel orientation of the collagen 1 fibers that gives you this ecotexture on ultrasound compared to the degenerative tendon. If you see this degenerative tendon, it is collagen type 3 fibers, which are no longer parallel, but form a lattice work or a network. And that's why you get a hypoechogenicity. And in that hypoechogenicity, it's a weak tendon, just like any network, lattice network is. There are micro holes already, so tears can happen easily. And this occurs in older people, middle-aged to older people. So in this area of tendinosis, you can see that there's a partial thickness tear. And if you notice, these type of injuries are not avulsion injuries like you see in the younger people. They are more within the area of the tendinopathy. And so you have them in this zone, which is more prone to tendinosis. That is the area that you would want to look at. So you can see that the calf pain can range from ruptures to partial thickness tears, and the etiology can be either acute ruptures in healthy tendons or tears in unhealthy tendons. Now you can have calf pain from what we call paratendonitis. Achilles tendon, unlike other tendons in the body, does not have a tendon sheath, as you are all aware, but it has connective tissue in which there is vascularity, and that can get inflamed, and that is called paratendonitis, nicely seen on Doppler with avid flow. So this can be treated very conservatively. Retrocalcaneal bursitis or retroachilles bursa are the two bursa along the distal insertion. Oftentimes they can present with distal calf pain because when the Achilles tendon slides on them, they could be radiating pain upwards, but most often it is at the heel. I just thought I would bring this in to complete the complex. So if you go to our case 1, pain in the, calf pain in the athlete, we have already learned the anatomy of the region. We've learned the biomechanics, how they present, the muscle myotendon tendon bursa complex, what imaging can be used, what's the diagnosis and the differential diagnosis, and how it impacts treatment. So with that, we complete our first case of PBL learning. Let's move on to a slightly more complex case. Posterior knee pain extending to the proximal calf. So here is a middle-aged male who complains of acute pain, swelling, and redness in the calf. Skin is discolored, as you can see. So the commonest that you would want to do is a Doppler ultrasound looking for DVT, as you all know, and you can see that there's a thrombus within the deep vein. The diagnosis is simple. We could have venous varicosities, which can get thrombosed, that is superficial thrombophlebitis or simply superficial thrombophlebitis that give a similar picture, again, can be diagnosed on ultrasound. Now here you have another patient with calf pain. Notice how it is completely thrombosed and looks like a vein. Now what we need to do is not give up our imaging here, but go more proximally to the knee. And then you would be surprised to know that this is actually organizing rupture of a complex Baker cyst. So if you go proximally, you can see there's some amount of discontinuity here, and this is the Baker cyst. And at the level of the knee, you short axis the probe, and you can see there's a semimembranosus, medial gastrocnemius, and you see the communicating neck extending into the joint, making the diagnosis of a ruptured complex Baker cyst. So this is a diagnosis that is oftentimes missed if you look at the structure that I had shown you, a linear area of organized collection. So we always tell our ultrasound techs who are not musculoskeletal trained sonologists that always go up to the knee before you call a DVT. Okay, so this was how they used to diagnose this way back. I got this image from the internet, where they used to do an arthrogram to make the diagnosis of ruptured Baker cyst. Again, I'm showing you a Baker cyst with a rupture that is organizing. You can use an MRI, but really you don't need that because this is an acute diagnosis to make. It's a simple diagnosis on ultrasound. Now let's move on to our next case, which is a 32-year-old with proximal calf pain. And I'm asking you, is this a Baker cyst? We said that it can have a communicating neck between the medial gastrocnemius and the semimembranosus. You see something like that here. It is bright on T2, but notice how there is no joint effusion. We all know that the Baker cyst is a potential space. Whenever the fluid is there in the joint, it can open up this potential space, and that's how you should always have fluid before you actually call it a Baker cyst. This was called a Baker cyst. Then the MRI was done, and in the MRI, you see it's bright, but it's not as bright as clear fluid. It looks like there are septations. So what is this? So if you look at the T1, it is more brighter than that of adjacent muscle. It is hyper intense to the muscle. So then we're saying, yes, this is a solid lesion, but not a cystic one. And then we know that it's myxoid tissue based on the T1 characteristics. So then it was biopsied and it turned out to be a myxoid liposarcoma. So always keep in mind the importance of looking at the T1. For intramuscular myxomas, myxoid MFH, and myxoid liposarcomas, notice that there is no fat component in these myxoid liposarcomas, and always give gadolinium to allow differentiation. So when you do an ultrasound, that looks atypical, but in the same location, and in this particular case, there was something like a neck, but there's no joint fluid. But always in every complex Baker cyst, put your Doppler. If there's Doppler flow and you can see a communicating neck, you know that you have to do an MRI with GAD to rule out a more sinister etiology. So this is how you'd arrive at imaging the Baker's complex Baker cyst to not miss sinister pathology. Another patient, 34-year, same age group. I'm showing you different pictures. Here you see a lesion. Neck, it looks like there's a neck. There's lots of edema in the muscles, and there looks like a slightly thicker wall, but there again is no joint effusion. Was called a Baker cyst. MRI shows that there is, T2 shows that there is solid component and cystic component, and there is surrounding edema. So yes, the next step is to give gadolinium, and gadolinium shows that there's enhancement of the solid component. And not only that, there's also enhancement of the surrounding edema, inflammatory edema that we had seen. So this lesion was biopsied, and it turned out to be a synovial sarcoma. So here in young adults, extra-articular in the extremities, around the knee, they're fairly common, and these lesions should be diagnosed very earlier on because there's a high level of recurrence and metastasis occurs quite fast. So when small lesions that you see, which you call ganglia or even bursae in that particular medial aspect, you have to be a little bit more careful and look for the Doppler flow in any complex lesion in a young adult in that location. We know, we are taught that 1/3 of them have calcifications on X-rays, but what about the other 2/3? They do not have. So these need to be kept in mind. Now moving on to a complex cystic lesion, we're moving to a 50-year-old adult from the 32 that we saw. And you can see that this was a cystic lesion that was first done with ultrasound. It has a slightly thicker wall. I don't see the communicating neck, but there looks like small little projection here. It is slightly more medial in the popliteal fossa than you would see with a complex Baker's cyst. Again, no joint effusion. That was the T2 image, which shows septation, some solid component within the cystic component. No communication with the joint. And then the T1 shows brighter areas within. So you know that bright areas can either be fat or they can be blood products. And then this is the susceptibility imaging that shows there's hemorrhage within it. And you can see that there is almost like a cap on the top, apical cap fat sign. And then this lesion was biopsied, and to our surprise, it turned out to be a thrombosed aneurysm of the popliteal artery. And so you can see how there can be various differentials for complex lesions in that region. Here is a 17-year-old. I'm going to a slightly older age groups, posterior lump and calf pain. He had arthroplasty, and you can see that there is some amount of soft tissue lesion here in the area. Despite the metal artifact, you can see it. In the axial plane, you can see that it has a slightly bright component to it. And this lesion was biopsied with synovial chondromatosis presenting with calf pain. So this, as you all know, it's a primary synovial process, monoarticular, with cartilaginous osseous nodules, and loose bodies can form from it, and they can actually become loose and are thrown into the joint. So synovectomy is the modality of is the way to treat these lesions. If you have simple synovial chondromatosis, then you can easily make the diagnosis. We are already trained to do that, but in a setting of arthroplasty, it's something to look at. Now, very often, almost on a daily basis, we see synovial and ganglionic cysts along the posterior medial aspect of the knee, and we know that they arise from the tendon sheath of the adjacent tendons. And they can sometimes have septations, as I show you here. What are they? They are nothing but hyaluronic acid being collected at synovial interfaces due to irritation and trauma of the tendon sheath. They're usually not symptomatic, but sometimes when they cause compression of the adjacent nerves, especially laterally the peroneal nerve, then they can cause symptoms. But one should always keep the synovial sarcomas for complex lesions, put Doppler on these cysts. And if there is Doppler flow, then you would want to call back the patient for MR imaging. Do not simply call that a synovial cyst without doing that. If there is pain, we'll do an MRI. So coming to cystic lesions, we can have large parameniscal cysts, as you all know, that protrude. We can, from meniscal tears, we can have cystic lesions like a synovial ganglionic cyst, in this case, arising from the proximal tip fib joint. But before we call this a synovial ganglionic cyst arising from the proximal tip fib joint, we have to know the anatomy that there could be articular branches supplying this joint, and this cyst could actually be an intraneural ganglionic cyst that tracks along the common peroneal nerve. So this is a no-touch lesion. You should not stick a needle into it. So that should be borne in mind. And then you would call the patient for axial MR imaging to see whether you can do axial slices to show the nerve and see whether the cystic lesion communicates along the line of the nerve. So keep this in mind before you call it a synovial or ganglionic cyst. So for our case 2, which is proximal calf pain extending to the popliteal fossa, we looked at DVT, which is the commonest, superficial thrombophlebitis. We've looked at varicose veins, which can get thrombosis of popliteal artery. We've already gone through the list of radiological mimics of a lump in the popliteal fossa causing proximal calf pain, from ruptured Baker's cysts, myxoid liposarcoma, synovial sarcomas, synovial osteochondromatosis, and complex cysts like parameniscal cysts, synovial and ganglionic cysts, and intraneural ganglionic cysts. So now we know the importance of developing algorithm so as not to miss the sinister pathology. So here, if you can demonstrate the communicating neck of a Baker's cyst on ultrasound, then you are good for it if there's joint effusion. If it is complex with septations and mineralized bodies and there is a neck, Even if it has Doppler vascularity, it could be an inflammatory complex Baker cyst, and the story ends with ultrasound. But if you cannot demonstrate the communicating neck and there is Doppler vascularity and there's no joint effusion, do an MRI to look for a sinister mass and then biopsy it. In this particular algorithmic pattern, you will not worry about missing sinister pathology. Now let's move on to a scenario of acute mid-calf pain. Here's an acute calf pain in the elderly. You can see that you put an ultrasound probe in the area of redness, and all that you see is edema within the subcutaneous fat plane. And you know the simple diagnosis is either cellulitis, which is infective, or if it is bilateral, then you're looking at other etiology causing the subcutaneous edema. That it is a clinical diagnosis, cellulitis. But if it is left untreated, there the radiologist has a role to play, because it can progress to necrotizing fasciitis, sepsis, septic arthritis, tenosynovitis, and osteomyelitis. So I won't go into further imaging and differentials there. So, but if you see gas, as you see here on the CT, we all know that we use CT to call necrotizing fasciitis. But interestingly, you will see dermal thickness, but you won't see as much subcutaneous edema as you would with cellulitis. You can see gas tracking in the perifascial plane. There's perifascial fluid, and there is intramuscular gas in this particular patient. So this is necrotizing fasciitis without uncertainty. But go back to a scenario where there is no gas. If there is no gas, it is not, you cannot rule out necrotizing fasciitis. It's a clinical diagnosis. So whenever you see a scenario like this without gas, we cannot say that necrotizing fasciitis can be ruled out. It is something that you'll have to put that gas is not seen. So we can't rule out necrotizing fasciitis, and clinical correlation is necessary. So then if you we do plain radiographs from necrotizing fasciitis, usually they start with them. You can see gas here, but sometimes gas is not seen. And so a CT is recommended because CT is highly sensitive for gas. Notice here the MRI was done, but the air locules are not as well seen as you would do with CT. You'll have to search for them. And that's why MRI is not the modality for necrotizing fasciitis diagnosis. Yes, CT again is good for abscess, where it will show air nicely, and you can see the rim enhancement for an abscess, and this can present with calf pain. So now let's move on to non-necrotizing patterns that we had seen with our necrotizing fasciitis picture without the gas. So here we are. Look at this patient. You have subcutaneous edema, you have perifascial fluid, you have intermuscular fluid, and some intramuscular fluid. So all these compartments are involved. Gadolinium shows slight enhancement. So it is important not to call this necrotizing fasciitis without the gas. It is as simple as looking at the history of the patient. If the patient has history of previous transplant, blood transfusion, stem cells, or thymic transplant, within 100 days of the procedure, you can see this type of a picture presenting with calf pain. And why is this so? Because the donor T lymphocytes react with the skin of the epithelial cells. There's vacuolization of the epithelium, and the lymphocytes will infiltrate the adjacent tissues and present with a picture that looks like this. So simply looking at the history helps you to suggest the diagnosis. Now we know that in collagen vascular disease of dermatomyositis, you can get fascial subcutaneous edema, fascial edema, intramuscular edema in the early stages with no significant loss of bulk of the muscles, but it is bilateral, and mostly it is in the proximal muscles. You can get extension to the calf as well, presenting with calf and proximal pain, but it is a symmetrical pathology. You can look at it on ultrasound, and you see calcifications like this, and plain radiographs that demonstrate calcifications in a slightly later stage. In the chronic stage, you can have sheets of calcification and atrophy of the muscles, and there's always the clinical picture in the background. So this is not a critical diagnosis to make. Again, like I said, this idiopathic auto-inflammatory myopathy affects early adults, females more than males, bilateral proximal muscle symmetrical involvement. Lower extremities are the commonly involved ones, and these are the diagnostic criteria by the American College of Rheumatology. Why I stress on this is the need to do an MRI rather than an ultrasound, because you want to see the entire region. And here you would want to decide where to do your muscle biopsy from. So that is the information that the referring person needs. So simply having a diagnosis of heliotropic rash, a background, and then doing an MRI, avoiding an ultrasound here would be the way to go. Now coming to SLE and myofasciitis. Again, similar picture. You have edema here, perifascial edema, intramuscular, interfascial edema. MRI is more sensitive to pick up the edema. Also, it provides better compartmental details, how many compartments are involved, which muscles are involved. Not only that, it can show the entire region, and you can look for osteonecrosis and septic arthritis, which are complications of lupus myofasciitis. And therefore here, MRI is the way to go. So lupus myofasciitis, this autoimmune disease, you know, is a multi-organ involvement and involvement of the musculoskeletal system, that is myalgias, arthralgias, tendinopathy, and tendon ruptures, is fairly rare. It is a small vessel vasculitis with lymphocytes infiltrating those tissues. It can present interestingly at any stage of the disease. You can get it earlier on or years after the onset. And if it involves the muscles, you'll get elevated creatinine kinase. So always look up the chart if you're looking at a myositis picture in the patient with myopathy presenting with calf pain and lupus myofasciitis. Now moving to the next case, you see redness in the mid-calf. So here, what is this? It is more let's say asymmetric. It does not involve the entire compartment of the calf, but you see there's involvement of the skin, subacute, there's perifascial edema and intramuscular edema of some of the component of the calf. So what are we looking at? Is simply by looking at the history of the patient, asthma, cough with calf pain. You're looking at what we used to previously be called Church-Strauss disease, called eosinophilic fasciitis now. They will have eosinophilia in their blood count, and you can either do CT or MRI, but the findings are non-specific unless you tie it up with the clinical history. It's a non-necrotizing fasciitis. So it is a small and medium-sized vasculitis. Typically, patients will have asthma, where there's eosinophilic rich granulomas, but they have peripheral eosinophilia, and the superficial muscle fascial layer collagen is infiltrated with lymphocytes and eosinophils. It is making this diagnosis is very important because it's easily treated with oral steroids. Again, calf pain in a patient with Church-Strauss disease. Now moving on to another type of fasciitis, which is the neutrophilic fasciitis, this time presenting with myofasciitis. This was an article that was published in Skeletal Radiology. So you can see that there's edema in the muscle, in the subcutaneous fat pain, perifascial intramuscular edema. And this particular lesion, you should keep in mind, it presents with high fevers, very critically in the ER. Never call this non-necrotizing fasciitis from the infective etiology that we have talked about earlier, because here you should not make an incision because that can lead to necrosis of tissues. It is called the Sweet syndrome. And as I said, rapid onset of erythematous warm edematous cutaneous lesions with neutrophils, this time not eosinophils, infiltrating the soft tissues. And there's absence of infectious cause. It can lead to myonecrosis. And the scary part of it is debridement results in expansion of the disease. So that's a no-touch lesion. So you should keep this in mind, that there is neutrophilia in the blood count. And this is something that you would look for if the patient comes from the ER. Then there is the last entity of fasciitis, which is the paraneoplastic fasciitis, where it is associated with hematological malignancy of leukemia and AML. It can either precede the malignancy, occur concomitantly with the malignancy, or herald a malignant recurrence. So while it is common in the face and neck, it can occur in the extremities and can present with calf pain of myositis, fasciitis, myalgias, tenosynovitis, and tendinitis. While imaging is non-specific, it's the peripheral count where you see peripheral leukocytosis with neutropenia, elevated ESR, and the history of leukemias, AML. This makes the diagnosis of a paraneoplastic fasciitis. So in summary, we've looked at non-necrotizing fasciitis. Pattern looks almost similar, whether you're doing MRI or you're doing CT. MRI is better, like I said. simply looking at the history can put the patient into these categories: graft versus host disease, eosinophilic fasciitis, Shockster's disease. We know that we're looking for eosinophilia, cough, and upper respiratory symptoms. Neutrophilic fasciitis, paraneoplastic fasciitis, where you're looking for malignancies. And you should have all these in mind before we look at the common ones that we call lupus dermatomyositis, which is bilateral symmetrical, and lupus myofasciitis. This is the connective tissue diseases that we all are aware of. Now moving on to an elderly diabetic who comes with mid-calf pain. You can see that gadolinium doesn't show much, but a T2 shows dramatic perifascial edema and a subfascial edema as well, and intermuscular edema. So then you already have the history there that the patient is a diabetic. So you're looking at diabetic involvement of these layers, but these people can also have diabetic myonecrosis. As I show you here, notice how there is no rim enhancement, as you would see with an abscess, and there are fragments of tissue. If you do gadolinium enhancement, these can enhance, and that's called the typical stipple sign. So this is diabetic myonecrosis. It is the history that gives you the clue. So myonecrosis is one of the complications. The exact mechanism is not known, but it is due to infarction of the tissue, because diabetes, as you all know, is arteriosclerosis. And so there's small muscle infarcts, and a larger area, if it loses its blood supply, it becomes non-vital, and that's how myonecrosis develops. So here is the slide to show you. I thought it's interesting, though I usually avoid using too much of pathology slides here. You see the normal skeletal muscle. You see the devitalized muscle here in this diabetic myonecrosis, and lots of neutrophils adjacent to it. Typically, however, the patient, unlike an infectious cause of an abscess, has no fever or leukocytosis. So in the chronic pattern is slightly different in a diabetic myopathy presenting with calf pain. You can see that there is atrophy of the muscles because there's muscle infarction, multiple infarcts leading to this. And on T2, you won't have bright areas as you would see in patients with the other etiologies. Now, from the diffuse calf pain or diffuse involvement of the calf, we come down to calf pain in localized areas, young male with subacute mild calf swelling. Put an ultrasound probe whenever you see something which is very narrow in a small zone, you can do an ultrasound. And you notice here, skin, subcutaneous fat, fascia. In the fascia, there's a nodular hypoechoic, almost encapsulated lesion, and there is Doppler flow. You can make the diagnosis of nodular fasciitis, which is quite common in the young age group. If you can do an MRI too to make the diagnosis, or after the ultrasound, make a in order to confirm, you can do an MRI. MRI will also tell you the histology. If you have a cellular variety, it's dark in T1 and bright in T2 and can enhance post-gadolinium. If it's the fibrous variety, it remains dark on T1 and dark on T2. And myxoid variety, as I showed you before, myxoid tissue will be slightly hyperintense to muscle on the T1. So you're making a diagnosis of the varieties of nodular or proliferative fasciitis, which is slightly different entity, but it is focal. So nodular fasciitis is fibrous proliferation of fascia. What is interesting to know is these lesions are small. They can occur in the extremities. Calf is relatively uncommon, but they can go rapidly in 1 to 2 weeks, and they get very painful. So they present as a painful lump, 1 to 2 weeks duration. But what we have to keep in mind is other pseudosarcomatous and sarcomatous lesions. So what is then in the middle age group, a slightly different but similar imaging appearing lesion is proliferative fasciitis. Age group, as you know, is older, non-specific findings similar to nodular fasciitis, and it is immature cells that look like sarcoma cells. Even the pathologist cannot make this diagnosis clearly. And sometimes they come back to us and it's a to and fro, we go back to them. So clinical pathological correlation is required, but oftentimes even that is not sufficient. So they usually do a follow-up to see if it is becoming an aggressive lesion, whether it's rapidly increasing in size, infiltrating tissues, and if its size is there a recurrence. So this is proliferative fasciitis. Then there's another entity which can look like a tumor, as you all know, but with a history of trauma, which is heterotopic ossification, which is here you can see iso-intense or slightly hyper-intense than muscles because it has blood products, chronic ones, and this is bright on T2, and it can be inhomogeneous, that is heterotopic ossification. Now that leads to pseudosarcomatous lesions that you should keep in mind: nodular fasciitis, proliferative fasciitis, heterotopic ossification, and of course, pyogenic granulomas, which will be typically having that history. So these are the imaging patterns that I have shown you of pseudosarcomatous lesions. I've not gone into sarcomas because I thought that would be an extensive one, and most of you are aware of soft tissue sarcomas presently. Now let's look at acute calf pain out of proportion to the level of pain presenting to the ER. And we all know that if the pain is very, very severe, it cannot be explained at the ER, you're going into a diagnosis of compartment syndrome. And we know that it can occur in multiple compartments, single compartments, and it's confined to one particular area. So let's see this patient who had a trauma. You can see a fracture of the fibula, and then they're presenting with compartment syndrome of the anterior calf or anterior leg. And you do the pressure measurements, any difference of 30 millimeters or more in the intracompartment pressure, you'll have to do a fasciotomy, a big urgent management that has to be done from the ER. So most of the times there's no time for imaging, especially in trauma, they just take the patient up. But look at other differentials. Here's a patient where they did an ultrasound, acute exertional compartment syndrome in an athlete. So patient is an athlete, presents with acute pain out of proportion. There's edema in the muscles. If you do an MRI, you see MRI in that particular compartment, and that is causing the tight, because of the tight space, the swelling is causing stasis of the venous flow. And from that, there's stasis of the arterial flow. And this is how they present with acute pain. Then another etiology that you look at is acute arterial thrombus. Notice here a CT was done. You can see that there is swelling of one of the muscle groups. There's fascial edema around it and compartment syndrome here, but there's lack of the blood supply in this particular compartment from an acute arterial thrombus. So if there's an acute arterial thrombus that gets dislodged, that is the time you can have a compartment syndrome. You can either treat it with anticoagulation, thrombolize it, or catheterize it with embolectomy. So when you come to acute compartment syndrome, you have to decide which compartment. In this case, I was showing you anterior compartment, and we've looked at acute exertional compartment syndrome. We've looked at trauma. You can have, and we've looked at acute release of arterial thrombus where you need to do recanalization, and you can get that from bleeds and burns as well. And you know how the diagnosis is made in the ER with pressure differences. The muscles get swollen. There's lack of venous flow because of the pressure of the muscles. There's reverse pressure, impedes arterial flow, and therefore the patient develops acute pain more than expected for that particular entity. Paresthesias, paresis, pain with stretch, pulse examination shows no pulse, and pink color. These are the 6 Ps that may help you to make the diagnosis, and it's a surgical entity. So, and it's a surgical entity. What I mean is it should be treated by fasciotomy ASAP. So when a patient presents acute treatment in the ER, it's truly an emergency. So we've looked at some challenges during the course of this talk, how we should differentiate early necrotizing fasciitis when you don't see air. When you see air, we all know how to diagnose it. When you don't see air and you say that you can't rule out necrotizing fasciitis, however, you keep in mind other non-necrotizing fasciitis differentials in your mind. And I have shown you the entire spectrum of eosinophilia, neutrophilia, paraneoplastic fasciitis. All of these you have to run through. We've talked about that. You have to ask for history of diabetes, but that can present as myofasciitis and, of course, compartment syndrome. And so the approach all through these entities has been clinical. Always the patient's problem was kept in the picture. The patient presented with proximal calf pain, and we looked at those entities. Presented with mid-calf pain, and we looked at entities. We looked at distal calf pain, where there's more of Achilles tendon, and always found the diagnosis to be related to the clinical picture from the outset. This is the PBL way of learning, which is the top-down approach. Now let's look at how radiological assessment is done based on the location of the symptoms of calf pain in this patient. Again, we move from proximal to distal. calf pain knee, we looked at ruptured Baker cyst and the mimics of ruptured Baker cyst, and we covered sinister etiology. We've developed an algorithm to remember how to do it. We've looked at proximal calf pain, and we've looked at solid and cystic lesions, mimics of Baker cyst in the proximal calf. In the mid calf, we've looked at simple ones like medial tear of the gastrocnemius, at plantaris ruptures and how to diagnose them. And we've seen how mid to distal pain can be seen with all of diffuse pain of fasciitis and the picture there. The mid to distal calf pain of plantaris rupture and distal third from Achilles tendon rupture. And finally, we've covered the entire diffuse pain region of the mid calf. What I have not covered during this talk is skin, where you can have pilomatricomas, which are lesions that arise when the hair follicle is obliterated or closed up. The contents collect there, and it involves the dermal layers and extends into the subcutaneous fat. The contents are echogenic. You put in a finger and you can push the contents to one side. This is the telltale sign of this painful, firm lump of pilomatricoma as an example. And I've not covered melanoma, where you put the ultrasound probe, and if you see lots of vascularity in an inhomogeneously hypoechoic lesion, then you want to image this further and biopsy it. Melanomas are very common in our part of the world, and we start with ultrasound. Now, I've not covered bones because of the limitation, but you know that if you can have stress fractures, you can have tumors like osteochondromas, where you want to image further for looking for complications, either the cartilage getting thicker or the neurovascular bundle being encroached upon. You can have osteoid osteomas. You can have various pathology, all of which can be covered with starting with plain radiographs first. So always, if it is not acute pain or how the presentation is, do plain radiographs. In our setting, in the ER, they do the X-ray and then come to us for further imaging. So with that particular entities that I've discussed, I'll now throw a quiz to you to see whether you found this PBL course kind of interesting. So let's see this. Our first case is a young female runner, severe pain radiating down the leg. We didn't know what we were looking at. She said she was saying the pain is along the lateral aspect of the distal third of the calf and going down. We put the ultrasound probe, which is the easiest to do, and we saw that there's a deep fascia here. We see skin here, subacute here. We're seeing short axis plane. We're seeing the muscles, and we're seeing the fibula. So we looked at the structure here. Looks like a nerve because it has a mottled appearance, almost like, and it has an echogenic line. And then we see that this is either thickened or there is something that is surrounding it. So we looked, is that the point of pain? So you put pressure with the probe, and that's the advantage with ultrasound. They can point, and then you talk to the patient, put pressure, and they say, yes, the pain is actually radiating from that point down. So then we said, what are we looking at? So when you Google it, of course, all of us do that, you can see that this is the area of the superficial peroneal nerve, and the nerve actually comes out of the fascia anterior to the peroneus longus myotendinous region, cuts through the fascia and then becomes a subcutaneous structure. So we were looking at the peroneal nerve running through the fascia. Then again, we asked her the distribution of the pain based on the cutaneous distribution. So we're looking at a little bit more of the anatomical anatomy in that region. Go back to our case, and we were able to call that impingement of the superficial peroneal nerve in the deep fascia. As it becomes from the intramuscular plane, it extends into the subcutaneous fat plane. So just by using the problem-based approach, you can see, keeping the patient at the center and his problem at the center, how you can make a diagnosis with the imaging that you have. And you're learning newer anatomy. So what did we do for this case? We did a hydrodissection and ultrasound, pressure injected around the nerve to release it, and then put steroid to treat the neuritis. So now that we have already learned superficial peroneal nerve, we keep that in mind. And we come to another case where the patient had severe pain radiating down the leg, again, a neurological type of pain. And since we now know that the superficial peroneal nerve's location in the subcutaneous fat overlying the fascia, we can see this nerve. And we can see that it's focally thickened. So are we looking at neuritis was what we thought. Then we didn't know what we were looking at. Look back at the plain radiographs. You see ghost screws. So the patient had some hardware. So then go back one more, and you can see that there was a broken loose screw. The screw head had impinged on the peroneal nerve. Patient was moving around there, and that's the cause of the neuritis. Hardware was removed, but the neuritis persisted. Again, we did a hydrodissection there with perineural injection of steroid to bring down the inflammation. Third case Severe pain radiating down the leg. Again, we got smart. We know how now we can look at the superficial peroneal nerve. We can see the deep fascia, and we see a defect in the deep fascia. So, but the nerve is looking normal here. Here again, it's looking normal. Unlike our other case, it's not passing through that defect. So what is this that is passing through the defect? So then we upright the patient, and in the short axis view, this was the first short axis view, and this is on an erect position. You can see the muscle bulging out. So you can see that there's a muscle herniation that has widened that defect through which the nerve passes, and so the nerve was being compressed by the muscle hernia. So that's the superficial nerve, that's the muscle hernia, this is the peroneal nerve. So simply by erecting the patient with foot inversion, we were able to diagnose this cause of superficial nerve entrapment, but this time it is impinged upon by the muscle which is herniating through the deep fascia. So again, coming to calf pain, in conclusion, let's look at tissue-based patterns that we have learned. I said we look at skin dermal lesions. You can do that with ultrasound. With bones, you can look at X-rays, but in between, we fill the tissues up. Deep fascia, necrotizing fasciitis, non-necrotizing fasciitis, fascial defect with muscle herniation. We've looked at muscle involvement in trauma. We've looked at muscles being inflamed, infected, and tumors. I haven't covered sarcomas here. Myotendons and tendons, and we've looked at tears and tendinopathy. And we've looked at the etiology, biomechanics of tendinopathy and ruptures of Achilles tendon and plantaris. We've looked at arterial involvement with diabetes, with arterial popliteal artery aneurysm and thrombus, and looked at DVT and superficial thrombophlebitis. We've looked at neural etiology in our cases with superficial peroneal nerve. So I think we've covered all the tissue layers using a problem-based approach. Now let's see whether we've done a radiological approach. If you're looking at the skin, if it's a small lesion, start with ultrasound. MRI, if it's a bigger lesion than 2 centimeters, less between 1 and 2, it's iffy here. Subcutaneous fat plane, if it is focal, start with ultrasound. If it's diffuse, start with MRI. Deep fascia, again, if it's focal, like focal nodular synovitis, you can do ultrasound. If it's wider, do MRI. So you see MRI is the way to go here. And you can do a CT instead if it's diffuse, especially if you're looking at a history of necrotizing fasciitis. Muscles, like I said, again, MRI is the way to go. The deeper it is, the more MR sensitive, because ultrasound does not have significant role unless it's a muscle abscess and it's very focal. Of course, nothing beats the air that you would see on a CT. So for necrotizing fasciitis or abscess with air, CT is the way to go. So we've decided on which modality to use for various problems of the calf. So you've seen that we've covered calf pain. We've learned the anatomy of the calf. We've learned the pathology involved, the biomechanics, if it were, and then the differential diagnosis and diagnosis. I hope I was able to show you the joy of doing the PBL approach. It's like having a basket full of fruits. You have all your differentials as fruits. You pick up the right one from keeping the clinical picture of the patient and what's the differential diagnosis always in view while you pick up your fruit and eat it. This is unlike the traditional approach where you will have to put in one block after the other. Like I said in the traditional approach, you'll have to fill an empty basket. So this is the difference in approach. I hope you've enjoyed this presentation. And with my respects to the memory of Dr. Kakala, who's been my teacher, it's a great privilege again, an honor to come back to KREST. Thank you all for your kind attention.
Thank you, Dr. Hema, for a wonderful presentation. The clinical-based approach, I think, is the best part of that. Thanks for taking us back to clinical medicine again. I request all of you to put your questions in the chat box. I see a couple of them already there. And I request Dr. Jaganmohan Reddy, who was our teacher and ex-colleague at Nizam's Institute of Medical Sciences, both for Hema and many of us here, to take us forward through the discussion. Dr. Jagan, please.
Thank you, Hema, for excellent talk. Actually, I really enjoyed. And you really following the legacy of Kakala.